Hello, everyone, and welcome to today's webinar, the Fertility Workup with Dr. Jill Attaman from Boston IVF. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Jill Attaman completed her medical degree at Michigan State University College of Human Medicine, her residency in obstetrics and gynecology at the Ohio State University, and her fellowship in reproductive endocrinology and infertility at Mass General Hospital, MGH. Dr. Attaman is committed to maintaining a high standard of fertility care and education within the New England region. She has served as director of the IVF unit at MGH and the chair of quality assurance for the division. Additionally, she has served on the New England Fertility Society Executive Committee for several years, acting as past president of the society. All right, we're going to get started, and I'm going to pass it over to Dr. Attaman.
Thank you very much for the nice introduction, and thank you to everybody who's joining today to learn more about the infertility workup, something that I am clearly passionate about. I have no disclosures for today. The intended learning objectives, I will be hopeful to define the definition of infertility, describe the infertility evaluation, discuss optimization of unassisted conception if this is applicable, as it does often come up during the infertility evaluation and workup. I'm going to start by going through a case, and I'd like to carry this case through the presentation so that we can apply what we're learning and reviewing to this particular individual and this person's partner. This is a 37-year-old G1P1. She's assigned female at birth, pronouns she, her, and her 37-year-old partner is a he, him with preferred pronouns. They present with a concern of increased time to pregnancy. The couple has not been preventing pregnancy for over 1 year. In fact, they've been together for a few years, haven't really had well-timed intercourse. However, they've been timing things very specifically over a 12-month period. The female patient has a 4-year-old child from a previous relationship. Time to conception during the previous pregnancy with an ex-partner was 2 months. This child does have cystic fibrosis. The patient reports regular menses on birth control pills, but they have been continuing to be regular since discontinuation 2 years ago. Cycle intervals are 28 days. So she's been doing quite well with her menstrual cycles, leading to some further frustration as to why pregnancy is taking longer than it did in the prior conception. No prior surgeries, no medications. She's taking her prenatal vitamin with folic acid. She started 3 months ago doing everything that she thinks that she should be doing to have a healthy pregnancy. She's employed as a school teacher, exercises modestly at least 3 times a week, follows a balanced diet, great nutrition, cooks at home, whole healthy foods, no history of gonorrhea, chlamydia, any STIs, no smoking, or using alcohol or other substances. So she is taking very good care of herself. And although it is not listed here, she reports that her BMI is 20. She's obviously in good health. The patient's partner also reports good health. He does not have erectile dysfunction, ejaculatory dysfunction, normal libido, has never seen a urologist, does endorse some stress with intercourse during the timing of pregnancy, feeling a little bit on the spot when things need to happen according to what they believe to be true to enhance their opportunity for pregnancy. He has no prior urogenital infections or exposures to STIs, no prior attempts to conceive, no medical problems or past surgery. In a partnered couple with oocyte and sperm, I often start by talking about what percentage of individuals will conceive after 1 year. This is surprising to some. Each month, the best probability of becoming pregnant, so fecundability, the probability of pregnancy, is 25%. Now, this is certainly age dependent. This is looking at all individuals, all ages. It will be different in somebody who is in an advanced reproductive age. After 3 months, nearly 60% of individuals conceive. Within 6 months, around 70. After a year, approximately 85%. After 2 years, just over 90%. We often use this information to define infertility. The probability that a cycle will result in a live birth is around 20% when there's egg and sperm in a couple relationship. This does not exceed 35%, even with carefully timed intercourse. Peak fertility is in the early 20s, so even young individuals that come in are surprised by numbers that are not in the 80s or 90s in regards to probability of having a live birth in any given menstrual cycle. Relative fertility is decreased for individuals in their late 30s and goes down from there. This is secondary to decreased ovarian reserve, increased oocyte aneuploidy, so abnormal chromosome content of the oocytes themselves, increased chromosome abnormalities of the embryos, miscarriage rates that increase, and incidence of disorders that impair fertility, meaning what a couple has gone through throughout their lifespan can affect reproductive health. I am an advocate that what promotes good general health will promote good reproductive health. Interestingly, as some of us may recall, the number of follicles is highest during 20 weeks gestation, even prior to birth. And then follicles deplete fairly rapidly. By the time an individual is in puberty, it's about 300 to 500 follicles. By the time the average age of menopause occurs at 51, there's about 1,000 follicles that are left within the ovaries that have the potential of releasing an egg and producing a pregnancy. At around age 37, which is close to where our patient is at, there's about 25,000 in total. Sometimes I use this diagram to demonstrate that peak fertility really is around the 20-year mark. And then in the 30s, it is decreased, but still very good opportunities. After 35, becomes more challenging. And by the time an individual is 40 to 45 years of age, pregnancy rarely occurs. So age is the most significant factor in outcome for pregnancy. This is also correlative to the miscarriage rates that we see based on advancing age, much more common in individuals that are in their 40s. Approximately half of pregnancies can be lost during a miscarriage. In individuals that never prevent pregnancy, we have several societies that fall into this category, coupled with egg and sperm and trying from all reproductive years until menopause. The average age of the last pregnancy when prevention has never happened is around 41 years of age. This does highlight the fact that it is exceedingly difficult for most people to become pregnant after that time. Historically, the definition of infertility has involved the time of attempts and the age of the individual. So the inability to become pregnant despite 12 months of trying to conceive without conception in women that are less than 35 years old, in individuals that are over 35 at 6 months of unprotected intercourse. ASRM has historically recommended when somebody is 40 to come in to an immediate evaluation with their OBGYN, their practitioner, an infertility specialist, or if there's any known condition to cause infertility. So the factors that are high risk for infertility: abnormal periods, an individual that doesn't have periods, somebody that ovulates every 70, 80 days. That's indicative of an ovulatory dysfunction and deserves immediate attention. Known or suspected uterine tubular peritoneal disease. Advanced stage endometriosis is a risk factor, or a known or suspected sperm factor. In 2023, at the American Society for Reproductive Medicine meeting, the definition of infertility was officially updated. This does continue to include the definitions based on time to conception and age, but it also is more inclusive. Nothing in this definition is used to deny or delay treatment to any individual, regardless of relationship status or sexual orientation, really focusing on the ability to help families grow and to build families. This includes the definition: the inability to achieve a successful pregnancy based on a patient's medical, sexual, reproductive history, age, physical findings, diagnostic testing, the need for medical intervention, including, but not limited to, individuals that need donor egg, donor sperm, or even a gestational carrier to carry a pregnancy. So consider referral when there's a known genetic carrier status, in addition to the things that we just mentioned: recurrent pregnancy loss, donor sperm and donor oocyte, interest in reciprocal in vitro fertilization, if there's two individuals with eggs that would like to go through IVF, one as a carrier, one as the egg that has created the embryo, and a medical need for gestational carrier. Infertility, as we know, is not uncommon. Approximately 15% of individuals that have constant exposure to egg and sperm will experience infertility. Often the etiology involves issues with both partners. And it's difficult to really pinpoint estimates as to how common certain etiologies for infertility are, mostly because it's difficult to establish causal relationships. Often more than one etiology is present, as previously mentioned, and these estimates are similar with primary and secondary infertility. This is a question that does often come up. If it was easy the first time and now it's more difficult the second, what are the reasons? Age will be one, because time has progressed. The other estimates also apply. Unexplained infertility is not uncommon, and this is one that I will highlight from this slide. Approximately 30% of individuals that are seen in a coupled relationship, sperm and egg, will have unexplained infertility. This means that there may be something that we just can't test for. Perhaps the way the egg and sperm come together, or the embryo has a difficult time with the cross communication with the uterus. There are different explanations. Perhaps fertilization doesn't occur. Male factor is also not uncommon on its own. It's present in about 20% of individuals. Together, it's about 40 to 50%. So this is one that is very common to see in combination with other etiologies for infertility. We also have ovulatory dysfunction with individuals with PCOS, tubal damage, some more unusual problems, and then endometriosis is commonly seen as well. During the initial infertility appointment, there's so much that we cover with folks. It's a comprehensive medical, reproductive, family, and genetic history, a targeted physical examination, optimization of reproductive health, which is what I will talk about because this does often come up in the initial workup and appointment. Preconception care: individuals that are aiming to become pregnant can have their preconception care prior to their pregnancy so that they have information and can address any concerns prior to the pregnancy. And then some genetic screening is often offered. During the history, duration of time trying, menstrual history is important to obtain, gynecological history, prior conception, as we know, how often intercourse is happening, if it is, any sexual dysfunction, are individuals having difficulties. I do address toxin, environmental exposures. Many folks are seeing things around them that may not be as healthy for their general health. Past medical history, surgical history, medications. Medications are important. Many individuals are on medications that do need to be discontinued prior to conception or addressed with a specialist or their primary provider prior to pregnancy. Family history can give us an idea if there's difficulty with fertility in the family. Social history, the smoking, vaping, marijuana use, any type of cannabis use, and then a quick review of systems. I do ask ancestry and genetic history in the family, including whether there's any known gene or congenital anomalies that could be present. The past medical history we have reviewed, and then I think I can move forward to this. So any prior testing that's occurred. Some individuals will come in with testing that is complete. Some will come into a fertility evaluation for the first time, just trying to learn more information. The normal menstrual cycle is around 28 to 35 days. We can consider 21 to 35 with some variability to be normal. It is interesting that, well, it's not uncommon that someone may come in saying that there are regular menstrual cycles occurring, but that's while being on a oral contraceptive, for example. So that's a falsely normal menstrual cycle. It's not one that's governed by the ovulation of the egg and the hormones that the uterus is seeing. Some have follicular phase variation. The luteal phase generally is relatively fixed at 12 to 14 days. During a discussion of fertility, we do need to think about how the brain and the ovaries interact with one another. Things start at the hypothalamus with the release of GnRH and move to the pituitary gland, seen at around the nose level in the brain. The pituitary gland will respond to GnRH with pulses of FSH, follicle stimulating hormone, and LH, luteinizing hormone. It communicates with the ovaries, and then the ovaries eventually first produce estrogen and then later ovulate and produce progesterone. These hormones are seen by the uterus and are preparing the uterus for implantation if pregnancy is expected. This slide demonstrates what's happening in regards to the hormones and the follicular development as well as the endometrium. During the early phase of follicular development, FSH is allowing small follicles to grow and develop. Initially, FSH starts to rise in the luteal phase. So during the luteal follicular transition, it's on a slow rise. After cycle day 1, we start to see it rise further. It's recruiting follicles. This diagram shows one follicle developing one egg. However, at the beginning of the cycle, there's a cohort, there's a group. It's a relatively competitive process, unfortunately. Individuals will recruit a variable number of follicles at the beginning of the cycle. However, one will become dominant, which is what we're seeing here, and estrogen starts to be produced. Other factors are produced that unfortunately cause the other smaller follicles that were not able to make it to undergo atresia, and those are not used again. So that was the cohort of follicles that was available for the cycle, which is the basic premise of in vitro fertilization, as we're trying to recruit that cohort of follicles that were available to grow but couldn't grow because of the dominance of the single follicle and egg. Eventually, that egg is making enough estrogen that causes a positive environment and an LH surge to occur. This is the hormone that people are finding on their ovulation predictor kits to turn positive if they're using them. It causes release of the egg, and then we have a corpus luteum that's left over. This is a review. The corpus luteum produces progesterone, a little bit of estrogen, and then the whole cycle will start again if pregnancy has not happened. During this process, the endometrium is becoming more receptive to the thought that there could be an embryo that will implant in regards to estrogen, first allowing the endometrium to build, and then progesterone exposure to promote implantation. ACOG and ASRM have a committee opinion that I think is very well done from 2019 that goes through the initial evaluation for factors such as that are crucial to infertility, ovary health, the uterus, the fallopian tubes, and the sperm. So these are the things that we really need in order for pregnancy to occur. And we need to assess the functionality as well as an anatomical assessment. Okay, so going back to our couple, what tests should be ordered for this particular case? Well, for these individuals, we will be discussing frequency and timing of intercourse and evaluating ovulation. These are questions that do often come into the office. Am I ovulating? I don't know. I can't tell. Ovulation predictor kits is the most cost-effective test for determining the likelihood of ovulation. Day 21 progesterone can also be used. However, this is a retrospective test. If we're drawing progesterone, it should be drawn 7 to 8 days after ovulation. And this can tell us whether ovulation has already happened. So a person would be in the luteal phase at the time that it's drawn. Basal body temperature charting has fallen out of favor just a little bit, but the charting is really complicated. It requires special equipment. People have to measure their temperature prior to rising. But these are all methods that are still being used, as well as apps. Sometimes they're just calendars that are estimating the time of when a person should be ovulating based on history. For our patient here in the case, progesterone was drawn on day 21. She has very normal menstrual cycles that are every 28 days. So this was an appropriate time, approximately 70 days after ovulation, and it was 1.2. Greater than 3 will indicate ovulation. So in this circumstance, this particular individual didn't ovulate, which is quite rare. It was repeated, and we did find that the individual was ovulatory, so 3 nanograms per milliliter. It was because the person was estimating cycle day 1 inappropriately. So we did say that this person is ovulatory. And for the purposes of this case, we'll continue with an ovulatory cycle. For ovulation predictor kits, urinary detection of LH occurs at peak levels. This means that ovulation will occur, meaning the egg will be released from the follicle approximately 14 to 26 hours post detection of the surge, because it's really hitting its highest mark at that time, and almost always within 2 days. Generally, we will say if we're using ovulation predictor kits to time intrauterine inseminations, for example, it would happen the next day if the kits are being used. False positives can happen about 7% of the time. Some of the kits just don't work for different individuals. And I do generally advise, if somebody is trying for the first time, to start using the ovulation predictor kits a few days before an expected ovulation based on their menstrual cycle. There are symptoms that can be appreciated. However, they're not noted in over 50% of individuals. They're pretty hard to determine for some folks. This includes changes in cervical mucus. The highest probability of conception is when the cervical mucus is slippery and clear. This is because the estradiol is rising. And this is really the peak time for fertility to occur and conception to occur, because the sperm will be in the reproductive tract. It will be in the reproductive tract for 3 up to 5 days duration in some cases. The cervical mucus will peak within 2 to 3 days of ovulation. Some people report pain, middle smirch, which is where they can feel the ovulation occur, increased libido, changes in mood. Moving on to the basal body temperature monitoring. During the follicular phase, we have a very steady temperature. During the luteal phase, it can change in response to the progesterone. It changes less than a degree, which is why we need thermometers that are marked in 1/10 of 1 degree. They are drawn prior to somebody rising out of bed, and they're retrospective. So it's telling somebody that the highest peak for fertility was 7+ days prior to when they're seeing the basal body temperature rise. So I find this to be one of the most cumbersome things, and one of the first things I recommend to discontinue if it's been documented more than once or twice. During the luteal phase, we did review that the peak progesterone will occur 7 to 8 days after ovulation. Progesterone will start to rise on the day of the LH surge, but it will be about 1 to 2 nanograms per milliliter. Anovulation occurs when the progesterone is less than 3, and measuring the level of progesterone is not a reliable predictor of luteal function. This is a reliable predictor of whether somebody ovulated or not. The corpus luteum produces the progesterone, and the progesterone is produced from the LH pulses, and these LH pulses fluctuate wildly, up to eightfold differences within 90 minutes. So it's very difficult to get an assessment of how much progesterone is being produced by a corpus luteum because of these fluctuations. Therefore, I use it as a marker for ovulation. Ovarian reserve tests. These are things that we may be doing in offices or referring for. It predicts response to ovarian stimulation. There are several different tests that can be used: FSH, LH, estradiol. We follow the typical patterns that we looked at in the prior slide. These are drawn on day 3. Anti-Müllerian hormone, which comes from the small follicles, and an antral follicle count, which is a physical assessment of the follicles. All these small little dark spots here are follicles within the ovary. Climate challenge tests have been falling out of favor, unfortunately, because we have many other tests that are quite reliable in estimating a person's ability to respond to fertility medications, dosages, stimulation, and outcomes from fertility care. I think we can slip over this slide here. AMH is derived from the granulosa cells, seen here, of the preantral and small antral follicles. So the small follicles that we saw in ultrasound are making anti-Müllerian hormone. This reflects the size of the primordial follicle pool, so that it can be obtained at any time in the menstrual cycle. Commonly, it's done on day 3 because we are doing other testing on day 3, such as the FSH, the estrogen, and the LH. It estimates ovarian reserve. This helps assist in selecting ovarian stimulation protocols in infertile individuals. It helps in determining dosing of ovulation the stimulation protocol, forgive me. It predicts stimulation response. Importantly, it does not reflect egg health or the chances for pregnancy in somebody without infertility. Age is still going to be the most significant factor in determining success with fertility treatments, despite what the AMH comes back as. So I do often add that in as a caveat. However, AMH doesn't do a lot for us other than help us with fertility care. It does not predict probability of pregnancy in fertile patients, not reliably predicting the trajectory of menopause. There is some data that is coming out. It is still a bit heterogeneous, so we'll see how that plays in the future. And it's also not a routine test that we recommend in fertile individuals because it is best as a predictor for how to go through fertility care if fertility care is needed. This is another picture of some antral follicles and also the uterus with the uterine lining. This uterine lining is quite thin, which is what we would see in the early follicular phase. Different ultrasounds, normal here. And we start to see variants. So this would be something that would look more like a PCO ovary. So polycystic ovarian morphology. The follicles are pushed out to the sides of the ovary. There is stroma in the middle of the ovary. The typical string of pearls is how this is described, with the follicles around the periphery of the ovary itself. This in and of itself will not diagnose somebody with PCOS, but it does have a typical appearance. And this would be more diminished ovarian reserve. In fact, it barely looks like a little ovary. Unfortunately, from an individual with low ovarian reserve, that is predicted to do poorly during fertility care. Diminished ovarian reserve is defined as an AMH less than 1, an antral follicle count that's somewhere between 5 and 7. I generally use 6 as my number. FSH greater than 10, history of a poor response, and prior IVF. So going back to our couple, we did this testing, and now we see a day 3 FSH of 8.3, which is normal. The estradiol at 50 picograms per milliliter, which is normal. AMH at 1.9, again a normal result, and the antral follicle count looked good at 15. So it looks as though this person is still doing well in regards to ovarian reserve. Age will remain a consideration. I feel bad if I'm being repetitive, forgive me. These are some normal values for reference. Now what will we do? Well, we know that the ovaries look okay, so let's take a look at the uterine cavity. And I do recommend a uterine cavity evaluation for people that are coming through fertility care. It's not something that is always required, but it is recommended. I think it helps folks choose the best treatment option for them, especially in somebody with advancing age. Can be an insurance requirement if a state is mandated to provide fertility care. The way that we can look at this would be with a sonohystogram, a hysteroscopy, or a hysterosalpingogram. We also look at the fallopian tubes. So the fallopian tubes are important because when the egg is released, meets up with sperm in that fallopian tube and eventually moves down and implants somewhere into the uterus. This can be done with an HSG or a hysterosalpingo contrast sonogram, which is commonly known as a HICOSI. There are some trade names as well. And then laparoscopy with chromoperturbation used to be the gold standard. This is surgery. There are many other ways where we can look without surgery, and generally those are preferred. Individuals with risk factors for uterine cavity evaluations or tubal factors should certainly have the evaluation. This is an example of a normal HSG. This is the type of catheter that may be used during the HSG process. It's small, kind of like an uncooked spaghetti noodle, which is how I describe it. There's a small balloon at the tip that you see here. Some of them look different, of course. It's introduced through the cervix with the use of a speculum, and then contrast is placed into the uterus. And you can see this nice inverted triangular shape to the uterine cavity. And these fallopian tubes, I think it's kind of fun to show patients their HSG if they have one. They're thin like little rubber bands, and you can see that the spill is coming out from both ends. A 3D saline sonohystogram can also be utilized. This is compared to what we see in Netter when we're looking at Netter for anatomy. A 3D sonohystogram will give us a nice picture of the uterine cavity, as well as allow for evaluation of the contour of the uterus, in particular the external fundal contour, which unfortunately I have cut off here just a bit. Here we see a sonogram that demonstrates a hydrosalpinx. So this was being done to look at the uterus, but we're also seeing that there's this cogwheel-like pattern and a dilated structure in the left adnexa, little slightly thickened walls. What other tests should be ordered for this couple? Well, we've seen that there's normal ovarian reserve, and unfortunately, this was a picture of our patient when she was having her ultrasound for a uterine cavity evaluation. Semen analysis. So the semen analysis is important as we need to look at the volume, concentration, motility, and morphology of the sperm. In general, we ask that folks abstain for 2 to 7 days, and that's based on the WHO criteria. The analysis is done on site within an hour. Individuals can produce at home and bring a sample in as long as it's obtained within that hour's time frame, or if there's geographic restrictions, it can be produced on site as well into a sterile collection container kept at body temperature, not outside when it's cold. If abnormal, it does warrant a further test with a second semen analysis. What you see here is the WHO criteria based on their fifth edition of individuals that are meeting the fifth percentile derived from approximately 2,000 men that have had successful conceptions within the prior year. I highlight the fifth edition, even though we're going to move on to the sixth, because in the fifth edition, the concentration here is 15, and often we still see concentration being reported. In the sixth edition, concentration is replaced by total sperm number, which is 39 million. But most of the time we're using a volume of 1.4 or 1.5, a count of over 15 million per milliliter, or if total sperm number is reported, 39 million. Total motility of greater than 40%, and morphology of 4%. That means that most sperm on a semen analysis will be shaped abnormally. So if moving back to looking at the sperm, there can be head defects, neck defects, tail defects. These things are analyzed on a semen analysis to get an idea of how the sperm is performing for a couple. And in this couple, the semen analysis, unfortunately, was poor. There's 2 million of 2 cc's of sperm, 4 million sperm per milliliter, again, less than that 15, 20% motility, normal being 40, 2% normal morphology, normal being at least 4. For reference, common terms that are used when describing semen analyses are listed on this slide. This individual has oligostheneteratospermia, meaning the sperm is low, the motility is low, as well as the shape. We have talked about the fact that a sperm evaluation and abnormality can be present in 40 to 50% of individuals that are coming in for a semen analysis. This would warrant a repeat and a referral to a reproductive urologist. I do like this slide because it does highlight different etiologies for male factor, a little bit more than what we'll go into, but there are some basic tests that are recommended when we see male factor present: the semen analysis, hormonal analysis, and occasionally some genetic assays, dependent on what a physical exam and history will tell us. For our couple, the endocrine evaluation showed normal FSH, LH, E2. The repeat semen analysis had remained abnormal again. There was an evaluation, a physical exam, which was normal. So our male patient has abnormal semen analysis parameters that have an idiopathic etiology. We did have quite a low count, therefore we did a karyotype, which would be recommended, and this individual came back with a normal male karyotype. So when we go back to our patient, we have a repeat semen analysis that remained abnormal, a normal evaluation with a reproductive urologist, and tubal factor with a hydrosalpinx. Now they're getting information at this point about what types of care may be important for them or most successful for them, and the female partner does opt for a salpingectomy. So we did see that the hydrosalpinges or the hydrosalpinx was quite large. And when we're going through in vitro fertilization, it can lower pregnancy rates by about 50%. And removal has a twofold increase in outcomes of IVF. So based on the factors that they've learned already, they have decided to go ahead and do this. And this is a picture of what the hydrocele pinks look like preoperatively and what it looks like postoperatively. Preoperatively, we can imagine that there may be some inflammatory substances here or fluid that can be going backwards into the uterus that can directly affect implantation or the uterus itself. This couple also will be opting for preconception genetic screening. They do undergo expanded gene screening. The partner is also a carrier for cystic fibrosis. So now they ask which options are available to them to achieve a pregnancy that is less likely to lead to a child affected by cystic fibrosis. For the couple, we will be talking about in vitro fertilization, probably with intracytoplasmic sperm injection, where we inject sperm into egg, and pre-implantation genetic testing for a monogenic disease, cystic fibrosis. Intrauterine insemination with donor sperm would be an opportunity, IVF with donor oocyte, embryo adoption, not expanding the family, and unassisted conception. So these are all opportunities that would be discussed with the couple when they come in. As we get to the preconception genetic screening, I'd like to take a moment to go backwards in the slides as the HSG and tubal evaluation pictures that I have in here have not adequately come through on the presentation. So here on the uterine cavity evaluation, when we're doing an HSG, I also have slides that will show you what a HICOSI or a saline sonogram will look like when we're looking at tubal patency, and pictures of what hydrocele pinks looks like. And I apologize that they have magically disappeared. So we'll go back to options for our couple. The couple has decided to go through in vitro fertilization with PGTM. There are some advantages and disadvantages to all of these options, but they do have choices. And successfully, they go through IVF, which will include ovarian hyperstimulation, egg retrieval, fertilization, embryo transfer, luteal phase support, cryopreservation, and prior to cryopreservation, testing of their embryos. So pre-implantation genetic testing for monogenic diseases for the cystic fibrosis gene. Now, they'll likely also opt for PGTA, as some of the insurers and genetics companies will combine the two, and this is for general aneuploidy screening. So we see pictures of a developing embryo through the progress of approximately 5 days duration until a blastocyst has developed. This blastocyst is around day 5 of development, and cells can be removed from the trophectoderm, which is the outer part that eventually forms the placenta, to be tested, removed, and sent for evaluation to see if the cystic fibrosis mutations are present. And this is what the embryo may look like after cells have been assisted to be extracted from the outer trophectoderm. And those embryos are cryopreserved. And then we talk about national outcome data. The 2021 national outcome data is on the SART website, and it can be viewed in different manners. Here, the first would be live births per intended retrieval, and under this, live births per first embryo transfer. These are numbers that are reviewed after the evaluation and while individuals and couples may be choosing their fertility options. In conclusion, I do recommend a reproductive assessment, as we have carefully gone through, considering risk factors and referral if present, and then referring for any individual that is interested in family building. as that is the ultimate goal. And I'd like to thank you with this. If we have extra time, we will be I can take some
We're
questions.
going to now begin the questions and answers, answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. All right, our first question is, if a patient is AMA over 40, do you recommend doing certain testing before sending them to you, or should we just send them?
I think an immediate referral is quite warranted when they're over 40. Very difficult to conceive, so we generally start everything right away. If for some reason there's a delay in being seen, testing can be performed, but often we're adding to the testing evaluation, and we can offer the care, so please just refer right away.
Sounds good. Our next question is, should patients begin taking any specific medications or supplements before their appointment with you?
Absolutely a prenatal vitamin. Huge advocate of folic acid. That would be the most necessary. So 400 micrograms of folic acid, unless there's additional need for more. I don't generally recommend supplements. Many individuals look at antioxidants, things like coenzyme Q10 or fish oils, and those are generally fine at this point. But the prenatal vitamin is really the focus.
Great. Our next question is for patients that have a history of cancer or those planning to preserve their fertility before undergoing chemotherapy or radiation. Are there any specific considerations for patients, and how would we refer them?
An immediate referral is necessary for individuals that are going through chemotherapy or cancer treatments, or planning on them. So calling the office and letting them know that you have an oncology referral would be the best bet to do so that they can be seen right away. And we have a number of providers that will have time and availability to see these individuals so that there's not a delay in their critical cancer care.
The next question is, how many rounds of ovulation induction for PCOS patients would you recommend before we send patients to you?
It depends on the diagnosis. So if you have an individual that has ovulatory dysfunction, just doesn't ovulate, and we do need an egg in order to become pregnant, then some folks are going through 3 up to 6 ovulation induction cycles. I generally recommend a referral unless you're comfortable handling the ovulation induction and prefer to do so on the practitioner's end. But most of the time we're going through 3 to 6, depending on insurance requirements and how everything else looks. But male factor is very, very common. So I do recommend a semen analysis, even if it's ovulatory dysfunction, and looking at the uterus and fallopian tubes to make sure that the time is being used wisely. Sometimes we see that there's a blocked fallopian tube for an unexplained reason, and the person is hoping to have, let's say, 3 children in the family, is already 35, then going to a different type of therapy may be the most efficient for them. And I do have some of those pictures that I can pull up. So here's just a few uterine images that I wanted to include, and they are looking for uterine anomalies, things such as structural abnormalities, polyps, uterine fibroids, intrauterine adhesions. These are a couple examples of HSGs that look a little different than the one that we had looked at before because of the positioning of the uterus. Here is an example of what a hydrosalpinx may look like on an HSG. And these are the type of hydrosalpinges that are very difficult to repair surgically, and generally IVF is recommended. For this type of picture, I would probably recommend bilateral salpingectomies if the individual is able to undergo surgery, or proximal occlusion is also an option. And this is an example of the tubal patency evaluation that I was mentioning earlier. What we're seeing here is the uterus. And then if we look into the adnexa, we're going to see little air bubbles, because during an evaluation where we're placing water into the uterus, we can then mix saline and air bubbles and look with ultrasound to make sure the tubes are patent. And we can see those air bubbles moving through here quite well. They're also within the uterine cavity and collecting there, but this would be tubal patency demonstration here. So this individual did have a normal uterine cavity, but we saw the left-sided hydrosalpinx taking it back to this slide. So thank you for your patience as I shared that. I can stop sharing now.
If a patient has anovulatory cycles and PCOS, how many cycles of letrozole would you recommend before referral for further treatment? You might have answered that kind of in your answer, but yeah.
Yeah, again, I would recommend looking at all of the fertility factors for that individual, even with PCOS. Letrozole is a great place to start, provided the tubes are open and there's sperm that looks okay. I would recommend after a few cycles if you're not wanting to refer immediately. However, an immediate referral is completely fine and advised if there's any concern.
This is the last question. Is there a BMI that would be a contraindication to assisted reproduction?
It's a really great question. BMI really does reduce probability of success for individuals if it's elevated or if it's too low. So elevated weight does deserve special attention. There's not a contraindication to pregnancy, but it does deserve special consideration. I would refer to a high-risk OB physician to talk about the risks of pregnancy with elevated weight. And then the person would likely need to be evaluated by an anesthesiologist to ensure that something like an egg retrieval would be safe, given if there's any airway concerns or additional health risks. The patient may need to be cared for in an inpatient setting if there's a need for potential intubation. And often IVF centers are outpatient settings, so there would be a further conversation that would need to happen and evaluation recommended.
Thank you. I did get a couple more questions.
Sure.
Does your team have an age cutoff for IVF or just depends on the results of the workup?
For in vitro fertilization with autologous oocytes, meaning the individual's own eggs, success rates are significantly diminished at 43. This isn't a cutoff. We do perform in vitro fertilization for individuals that have more advanced ages, but it's really individualized. Beyond 44, we really have to have a distinct conversation about what IVF may be providing and how it may not be changing outcomes in comparison to unassisted conception.
And then this is our last question. Are there any supplements that help with male fertility?
There are some supplements that are recommended by the reproductive urologists, motility agents. There are some products on the market that can be used. I recommend a generic multivitamin as well as antioxidants. Sometimes the sperm can be a little bit less healthy, even though a semen analysis looks okay. DNA fragmentation is something to consider, and antioxidants may be of benefit. So I would recommend similar things such as fish oils, which could be beneficial, or focusing on nutrition specifically, and any other exposures that could help improve general health, such as exercise, nutrition, making sure weight is within a normal range.
Thank you, Dr. Attaman, and thank you everyone for attending today's webinar, The Fertility Workup. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey of the presentation, and we would appreciate it if you complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Jill Attaman, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Attaman.
Thank you. Thank you, everyone.